Hello, welcome to another episode of True Cars and Corolla. And today we are going to focus on when less is more in a case of retinal surgery. This is a case of a chronic coloboma RD in a 14-year-old female. And what we can see is that there is a bad pucker involving the fovea. And generally, in such chronic coloboma RDs, if this such of pucker is there, then it generally indicates that the chronicity of the RD. We grab the vitreous at the pucker itself and proceed with the PVD induction. As we all know that PVD induction is one of the toughest challenges while we are dealing with a coloboma RD. The issue with this is that the retina becomes so thin and the vitreous itself associates some sort of opacity that it is very difficult to sometimes distinguish whether we are holding the retina or whether we are holding the vitreous. We somehow proceed with it and proceed with doing vitreous detachment by using an ILM forceps. Now here we notice that there is a bad pucker involving the macula, and there is a lot of urge to go and dissect that pucker and unfold it. Somehow we are able to resist it, and we proceed with the vitreous detachment by using of the cutter and the forceps. As we proceed in this case, at this margin, we see that the intercalary membrane is detached, and I feel there are a lot of pigment deposits at that point. I suppose that this was the primary source of break. Unable to find where the primary source of this is, I proceed with the complete dissection of the intercalary membrane and complete resection of the intercalary membrane, and along with the associated chorioretinal tissue that is present, leaving it intact at the motor margin. I proceed with first dithermizing the major blood vessels and continue with the dissection of the intercalary membrane by using the chorioretinectomy sort of thing. It might be choriointercalary membrane dissection. I have avoid the temptation of going anywhere which is going too close to the fovea, and after doing this, this is the point which felt that must be the source of the chronic RD, as we were not able to find any other source in this case, so we proceed with it. After doing this, we stain and look for the ILM at the macula. In this case, we were able to grasp the ILM at different sites, and it was coming in bits and pieces, and we were able to proceed it. Now look at the macular anatomy or the foveal anatomy, and we see that we could have gone and tried to dissect it and try to unfold it, but we avoid this temptation as much as possible. The point I want to emphasize is that these chronic RDs have, due to its own retinal edema, have an architecture which is an intrinsic sort of swelling, and the point of unraveling it or completely unpuzzling this sort of configuration during the surgery might be catastrophic for the patient as well as your surgical outcome. So we should avoid this temptation. Because of the chronicity of the disease, the macula has formed such type of configuration, and in the subsequent post-op picture you will see that the beautiful foveal anatomy that it attains by its own physiology, which was surprising for us also. We proceed with doing a few day exchange and then doing a laser all around the coloboma, and look at the left side diagram and see how beautiful the foveal anatomy is. Thank you for watching this video.